Hi New Zealand, my name is Dorthe Tomsen. I'm a chief pharmacist from North Zealand Hospital in Denmark. And what I'll share with you is the work that we have done on opioid-induced constipation. This work has been going on since 2012. And we've been working with wards all across the hospital in order to get to some kind of solution to the problem. The work has been carried out by a team consisting of doctors, nurses, pharmacists, and pharmacy technicians. And it has been very useful for us to do this interdisciplinary work, because that is what it takes in order to get into the very root of getting rid of opioid-induced constipation. We started out detecting the problem back in 2010. When we looked at our data on readmission, we could see that constipation was one of the 10 most common reasons for getting readmitted to our hospital. The cost of these readmissions were around 2 million Danish kroner a year, which is a substantial amount, so we had to look into some further investigations in order to find out what we could do to the problem. So we turned to our harm profile. The harm profile is done by using the IHI Global Trigger Tool. And from the very beginning, we had constipation as one of our triggers that we looked for. And as you can see behind me, it's very obvious that constipation is absolutely the #1 top harm that we introduce to our patients while they're in the hospital. So we had to look further into it. So what we did was that we looked into the medical charge. And in the medical charge, we look for different ways of screening for patients being treated with both opioids and laxatives. And in the beginning, we thought that we should just tell the technicians that they could look for opioids, but they were in the beginning to be in doubt. Is it just morphine? Should it be both the strong opioids or also the milder ones? Or should we also take on the PN opioids that is giving to our patients? So we had to go through several of PDSAs before we had a screening tool. And what we ended up with was that once a week, the pharmacy technician would look into the medical charge, and she will find all the patients being treated with opioids, and this was all kinds of opioids. And then at the same time, she looked for some kind of laxative. It could either be as something there all the time or as a PN prescription. These data were as a good predictor for if there was something to work with on the ward. So we went on and looked for traditional ways of doing interventions to this problem. And the interventions that we introduced was based on pharmacology, nursing, and communication, and nudging. And the pharmacology side, we looked at all the traditional ways of doing this. Could we make some guidelines that were easier for the doctors to use? Could we teach doctors and nurses about being aware of this opioid-induced constipation as the most common side effect of treating with opioids? And could we do something about the prescribing system so it was so much easier for the doctors when they prescribed an opioid, they would be actually nudge it, should we at the same time prescribe a laxative? So that was one part of the interventions. The nursing part turned out to be very, very important, because in order to determine whether the patient was constipated, you had to have the nursing staff as a very important team player here. And it's not always that easy for the nurse to talk to the patient. But we did some different things with making tools that they could use in their conversation with the patients. And then we did an overall conversation strategy, trying to put the problem right there on the bill line and saying to people, this is actually something that we have to take into account when we're treating people for pain. But what we found out was that this traditional way of going around the problem, we didn't really have a breakthrough, because talking to the nurse about how you're doing with your stool is a big taboo for patients and for some nurses too. We actually had some nurses who would document that yes, they did talk to the patient, but the patient wouldn't really recognize that they had discussed constipation. So this was very obvious that it wasn't an easy task to take on. So we developed different things that would try to help break the taboo. And one of the things that we had a lot of success with was using children's drawings, notching both nurses and doctors. The nurses were notched in the dispensary, and the doctors by the computer where they actually did prescribe their opioids. So they would all the time be reminded that they should be aware of if there should be a laxative prescribed too. And then we made some different tools for the nurse to actually go into conversation with the patient. One of the things we did that we made a pocket leaflet that the nurse would carry around with her and then use it in the conversation so the patient could actually point out what kind of stool they had today. We used patient information leaflets telling the patient that was very, very important that they talk to the nursing staff and to the doctors about how they were doing. And then finally, we did the notching part, which was pretty extreme, that we actually put posters at the toilets telling the patients, while you're here, you could just as well look at this poster and make up your mind if you should talk to your nurse about how you're doing with your stool. So we have been going through different paths, and actually today we have 2 wards who have succeeded in getting rid of opioid-induced constipation because they're very, very good at remembering to talk to the patient and to prescribe the laxatives when it's necessary. We still have a way to go at all of the other wards at the hospital, so whatever you find out in New Zealand, please share back, because we will be so thankful if you could send us some help too. And thank you for letting us share our work. We're always proud to do that, and thank you for listening.